Menisci are important structure in the knee which are responsible for load sharing, stability, and shock absorbing mechanism while performing day-to-day activities. Horizontal cleavage tears or the medial meniscus are one of the important pathologies which gives rise to pain while squatting, using a staircase, and sitting cross-legged. These tears are usually present onto the medial meniscus and they are hidden sometimes between the two leaves of the meniscus. A basket punch or a duckbill nibbler is used to expose this horizontal cleavage tear by performing a partial meniscectomy. The principle here is resect as less as you can and save as much as meniscus one can, because the amount of the meniscus tissue present is directly proportional to the function of the meniscus. Once the meniscus has been resected, a trajectory is chosen and the portals are switched to have a better trajectory for the meniscus repair with the all-inside device. Now we are viewing from the anteromedial portal and the probe is coming in from the anterolateral portal. Once the meniscus has been probed, a golden awl is used to freshen the edges of the torn meniscus. That is the flap tear which you can see, that is the superior surface of the meniscus, that is the inferior surface of the meniscus, and there is a horizontal cleavage tear between the two surfaces of the meniscus. The probe will come out and a golden rasp is used to rasp and freshen the areas of the two leaves of the meniscus, so that this abrasion of the meniscus gives rise to improved biology for repair of the meniscus, and successful repair would give rise to a proper meniscal functioning. After seeing the trajectory, the scope is reshifted to the lateral portal and all-inside cannula comes in through the anteromedial portal. That is the all-inside device which one can see with a curved needle. The first pass is made onto the inferior capsule below the inferior leaf of the meniscus, and the second pass is made onto the superior surface of the meniscus near the meniscocapsular junction. Once these two passes have been made in a proper trajectory, as far as possible perpendicular to the meniscal tissue, the device is withdrawn and the thread is pulled so that the knot can seat onto the repaired meniscus, and this approximates both the leaves of the meniscus together, thus sealing off the horizontal cleavage tear. A knot pusher can be used to seat the knot in such a way that it faces onto the inferior surface, and abrading of this suture material onto the cartilage can be avoided. The scope is reshifted to the anteromedial viewing portal and the second device comes through the anterolateral portal, again with a curved needle. The inferior capsule is pierced with the device as a second suture, and then the second pass is made in the similar fashion onto the superior surface of the meniscus at the meniscocapsular junction. Once these two passes have been made, the device is withdrawn, and as we saw previously, the thread is pulled so that the knot seats onto the meniscus. That is a chondral damage which one can see, which has occurred because of the meniscal tear. That chondral damage is gently shaved off, doing a small amount of chondroplasty, and now one can see that the repaired two